So I'll do a little presentation next time, and then with the tech, you can kind of see it over there. In the old days, we used to use like a water. It's to do what are called pulmonary function studies, which now they're all pretty much done the way we would do them here, electrically. More advanced technology. In the old days, you would have like an analog device that you can see over there, measuring how much air you could take in and take out. It's less about young healthy people. They use it for young healthy folks in sport. And down the road, so what we'll look at, and most of you probably had respiratory by this time in the lecture, I would guess. Okay, well, I'm going to do the anatomy part the way I do it. And then, so we don't have a lot of time. We don't have a lot of time together. Yes, dear.
When will we find out our grades?
I will get those posted by Friday. Okay. I forgot all about it. I looked this morning, and I was doing other kinds of grading. I'll get it done. The ones I looked at were good, so it's not. I'm not anticipating there's going to be much carnage.
How many points was that?
It's the same as the other one. I mean, was it like 20? No, I think it's like 20 points, 30 points, I think.
Okay.
So I don't remember. That's above my pay grade. So I'll show you. This is in B. It's this. This is the physiology part. You may have had this before, but it's fun to understand where this all came about and sort of the context. So we're not going to do it today because I don't want to give it short shift. But it's when, as I sort of scroll down to these things, this kind of stuff, all these different, that's the non-movements, that's the imbalances. I must have skipped over it. Sorry. Maybe I didn't skip over it. Hopefully, assessing, the volumes and capacities part of it. Because we can actually do that, and you can see it's very interesting, and they're used a lot in the context. I'm doing my respiratory unit in my advanced physiology class now, and we do the physiology aspects of it, but it's very, very interesting to see how that's how we evaluate people for chronic respiratory diseases. And respiratory diseases are maybe now a little less, but the people that many of you, if you go into nursing, will see are people with long-term respiratory problems, long histories of smoking. I think we're seeing a certain diminishment of that particular statistic. But let's say when I would have been in your position, that was hardly the case. That was there. So to that end, a couple of things I'll share with you. I just posted this. I sort of tweaked it a smidge. This is an outline for everything. If you've already had an exam about this, then you had an exam about this. But this covers the anatomy and the physiology and some of those studies that are there. If it's of interest to you, then take a look at it. There's a number of interesting effects. When I do the physiological aspects of it, which we won't be doing here, there's a lot of interesting material that goes along with it. But for now, we'll just focus on the anatomy. So let me get started with the proceedings as a whole. So respiratory syndrome, and I will tell you, just to show you get the same high quality information that I give to my advanced physiology students. I can sum this up in a sentence. Respiratory. In with the good air, out with the bad. That wasn't hard, was it? See, I got it covered. So this is the whole idea. The textbook here plays around with terminology. See, there's ventilation and respiration and all. So we're dealing with the pulmonary aspects of it, okay? And I really think that's when we get at the cellular level, we say touch on it, and you probably touched on it in physiology to some extent, the cellular respiratory aspects, and a little bit about smell and speech certainly play along with it. They use this, ventilation for breathing, as opposed to respiration strictly being the exchange. To me, that's a little putting too fine a point on it. It's pulmonary respiration. that's bringing the air in and out and the exchange process that occurs. Whereas transportation, what they choose to call internal respiration, to me, should more aptly be called cellular respiration because that's where it occurs. So there's not a whole lot other than the way they do that, and to me, the underscore of all of this is sort of this intimate relationship that we see between the cardiovascular system. So these 4 units in a row that nearly every anatomy systemic textbook presents, where they do blood, the heart, blood vessels, and respiration, they're together because the only way the system works is if they're equal. Whatever the heart pumps out, the heart pumps out 6 liters of blood a minute. We call cardiac output. The minute volume has to be 6 liters of air being put in or out. They've got to marry. If they don't, it creates an imbalance, and imbalances create more. There's going to be adaptation. If you go to elevation and there's less oxygen available, different things are going to happen. Okay, your heart's going to have to work harder, your lungs are going to have to work harder. Eventually, your bloodstream is going to increase the number of red blood cells by way of erythropoietin. Your blood's going to get a little thicker, but you're going to adapt. It's going to take a month, maybe 2 months, depending on who you are, for it to satisfactorily adapt, but you'll adapt. So, because eventually those systems have to be equal. There's nothing unusual about this. And the interesting thing to me, and when we get to it, maybe I'll talk about it a little bit next time because I think it's important. And if I'm really feeling frisky, I'll get out a lung and we can kind of take a look at how it is anatomically as a demonstration. Is that if you get deep into the physiology, it's a classic area about something that happens in our bodies that's two-edged sword. It's wonderful and it's harmful. It gives you a false sense of security. In your kidneys, when we get to that, you only need about an eighth of your kidneys. You need one kidney, you need the other one, about 25%. So that's 1/8 of actual kidney regular functional portion of kidney to be able to work, for you to be able to conduct kidney business. Okay? If it goes under that, now you're going to need dialysis. But up until that time, you don't get a clue that there's anything wrong. Same thing with your lungs. One day you'll be breathing, an older person with respiratory problems, will be breathing, will be fine. All of a sudden, have difficulty catching your breath. They're going to see the doctor, they're going to be testing, they're going to say, you're going to be an oxygen for the rest of your life. But it was fine yesterday. That's one of the neat things in an odd way about the body. You have all these compensatory mechanisms that kick in and protect you until it's too late.
Isn't it something like if people have COPD, like there's really signs before something happens?
Oh, sure. I mean, that's the key. You hit the nail right on the head. The whole idea is when you start to see these things. Like, I mean, you don't be a rocket scientist, a long-term smoker like I was, that's a problem. That's when it comes away. There's no way to avoid it. But for somebody else who, let's say, doesn't have a lot, maybe there's something occupational, and they start to experience those kinds of things, maybe on exercise, difficulty catching their breath, doing certain activities. That's like a little alarm clock going off saying, hey, take care of it. It's kind of what, in a way, it's kind of what happened to my dad. He didn't intend to it. I know why he didn't intend to it. But all of a sudden, when he finally reported it to me, it's like, oh my God. And he was in big trouble. I mean, he died not too far after that. I relatively lived for ostensibly a very healthy man. I mean, to look at me, you wouldn't guess it. My dad was 6 feet tall. Where were you with the genetics? 2 male cousins who are 6'3". Me, vertically challenged. You know why I say that? Not overweight. You know why? I looked at those height weight charts. Big frame, 5'8.5". I should be 6'6", 6'7". It's not the weight, it's the height. Vertically challenged. But my dad all of a sudden is describing a fancy thing called intermittent claudication, where he's telling me, you know, I go out to get the mail, I go out to get my car, where he's looking, I have a little walk against the garage, to the apartment. it just starts to cramp up, and I stop, and it goes away. By the time I look back to our apartment, mom and I, it starts up again, so I stop. That's pain on rest, relief, pain on ambulation, relief by rest, independent of position, is the definition. That means there's a major blockage someplace. And it turned out that was the alarm clock that, I hate to say chose to ignore because they were at the time. And by the time they addressed it, it was great, it was good. He didn't survive with the punch. You know, and a long time ago. Okay, maybe there are things that we could say, I've been around 35 years, this is a lot of us. And I say it all the time, it's just the way it is. So that's part of what I hope I'm conveying to you with some of these anecdotes and things like that. That, you know, there are signs that you can't do more than, which is, well, I was sleeping for 40 years, and, you know, you're the person why I like you. So I find out, you know, I told you I had bladder cancer, and I had a lot of procedures that were done. And it's nothing about cancer again, it's just that there's some complications that are right after the rest of the summer. Again, good. Yeah, nothing major. If it was major, they would have scheduled me this week rather than until June to do a procedure. But, you know, it's not, you know, that's kind of how you tell the doctor. They want you, but we don't need you to come in next week, you got to come. We'll see you in a couple of months, we'll figure it out. Okay. Maybe I get some sympathy out of my wife. She won't force me to do all that work around the house for a day or two. Nah, probably not happening. That usually gives me about a 24-hour without being yelled at. And again, I know exactly how to respond to her. Yes, dear. Here we go. So here's the drill. There's two ways we divide the respiratory system, anatomically and physiologically. And there's a lot of systems that are like that we're getting to. Okay, anatomically, respiratory is divided roughly at the larynx, to upper and lower respiratory systems. The larynx is somewhat arbitrary. Technically, head and neck would be considered upper, chest would be considered lower. The larynx is about midway into your neck. So it depends on the author you read. To me, it's not a big deal. But sometimes the larynx is part of the upper, sometimes the larynx is part of the lower. Just giving you that. There's a lot of interesting nuances to this that are there. It is a relatively small system if you look at it surface area wise, but if you inside, it's miraculous how much surface area there is in the lungs. That's because of the construction of the alveoli, these wonderful ball-like structures that are nothing more than membrane. We'll have a lung here someplace that I'll get a hold of and show you next time. Lung is typical organ tissue. It's very soft, pliable. It's not like muscle, which is firm and dense. Lung is mostly filled with air and blood vessels and membranes and little hard structures, which are effectively the wind passageway, which are bronchi or bronchioles when they're sufficiently small. That's all they are. Other than that, it's really a chamber that's designed to keep open so air can go in or out. How it is kept open is by a series of structures that are firm and can't be compressed. They are all, without exception, made of cartilage. And if you recall back to AP1, when you learned about tissues, the cartilage is sort of a semi-compressible material that's on the sort of somewhere not as hard as bone, but certainly not as soft as connective tissue. And there are three types of cartilage. Hyaline, which is the respiratory cartilage, with one exception, which is the epiglottis, which is the elastic cartilage. That fibrocartilage was like intervertebral discs, things like that, menisci in the knee. That's the first issue. It's cartilage that keeps it open. When the cartilage goes away, as the tubes get smaller and smaller, that's effectively when they change, when they're no longer moving the air, but they're allowing for the exchange. And that's the functional division. We have a conductive division, air in and out, and we have a functional division, which is the exchange. Once the cartilage goes away, the air that you have breathed in, rich in oxygen, is so close to where the exchange takes place in these alveoli, in these ball-like chambers that are just made out of cells on one side with blood vessels on the other side, that it happens almost instantaneously due to your old friend from AP1, simple diffusion. Oxygen this way, carbon dioxide. You remember that. Transmembrane, boom. Concentration gradient, boom. Happy days. In with the good air, out with the bad. And we reverse the process when we get down to the tissue level. Not a whole lot different, except then we're not dealing with cartilaginous passageways. So it's relatively small if you think of it length to width without looking at all the surface area that's involved. A lot of hidden surface area, so to speak. You have the nose and the nasal cavity, bigger than you think. I mean, some bony landmarks kind of are part of it, but they really are boundaries as opposed to being construction material. Mini chambers that are inside for resonating. That's where you would see nasal sinuses and similar things. They're 4 bones. You might remember from AP1 that are called paranasal air sinuses, FEMS. Okay, frontal, ethmoid, maxillary, and sphenoid. FEMS, the way I do it. Because MEFS does, I can't remember. It's the way I do it. And another opening in there that goes to your ear. That's the eustachian or pharyngeotympanic or auditory tube, whatever name you want to use for it. It's the remnant of the pharyngeal pouches that all vertebrates have. You remember from your high school biology. That's where it comes from. That's really part of the nasal, and we'll look more into it in a bit. That's there. I don't go crazy with a lot of the anatomy with regard to the nose. My focus point is trachea, is larynx, trachea, and lungs. That's where the focus point is for the anatomy I'm interested in. Okay? So they're going to show it to you. What's part of it? The larynx has a lot of different cartilages. The trachea, cartilaginous rings that are C-shaped, oriented horizontally, open in the back, like a letter C, but it's open in the back. The bronchial tree, very much like this. The alveoli. Alveoli, the best analogy for an alveoli is, you're going to love this, puzzle ball. If you like jigsaw puzzles, the ones that you can make a globe out of, puzzle ball, Ravensburger is wonderful. For you, no puzzle fans? Don't like puzzles? Oh, puzzles, we sold a ton of puzzles during the lockdown. You couldn't keep jigsaws in stock. Love that stuff. We got a puzzle ball yesterday to sell. And the lungs themselves, we'll get into it. So upper, what's the nose do? Filters, nose hairs, moistens, warms, because air at the appropriate temperature and moisture level is easy to exchange. That's why it's there. So it's an opening, warming, moisturing, filtering, cleaning, resonating, olfactory receptors, etc. So you have the nose itself that protrudes and the nasal cavity. So they have a whole lot of this. The root is really the bony part, your nasal bones. You remember they're not part of the orbit, so-called bridge of the nose or root, and everything else is cartilaginous. The openings are called nares, and that's about as much as you need to know about it for me. Nice looking nose. See, there's the bony portion. The rest of this is all cartilage, and I don't give a good gosh darn about any of those names. I know you're unhappy to hear that. You don't have to know your alar from a hole in a wall. That was supposed to be funny. The divider is a septum. That's cartilaginous. Only when you get deeper into the vomer and that perpendicular plate, if you remember from Anatomy 1 and bones, that's the bony part of the septum. That's relatively deep. So when somebody breaks a nose, it's usually up here. Okay? When someone has a rhinoplasty, a nose reconstruction, cosmetic or functional, it's mostly about the cartilage. They sometimes will break some bone to do that. In the spirit of being fair and transparent with you people. In 1986, I had a rhinoplasty. I was born with a Jewish nose, since I had a Jewish mom and dad. So I had the hook. It's all right. And I had my nose broken about 7 times. I tended to get into a lot of fights as a kid. It's true. Here's my mom. I'll have a good time today. Don't get into a fight. Parents were different then. Now, it'd be all over. They'd sue somebody because the kids got into a scuffle. Okay? So that's it. All this other stuff, the hairs and the vibrissae, don't care. Olfactory mucosa are the special sense portions of it that have the sensors that we use to discriminate smell. The respiratory, this is important, pseudostratified ciliated columnar epithelium. I'm a nut for epithelial tissues. You should know that by now. That's the landmark epithelia of the respiratory system. You see goblet cells make mucus. We see those in 2 areas, respiratory and digestive. Where we see faults with the mucus when sticky, if you have a disease called cystic fibrosis, that affects respiratory and digestive. It's about the mucus. Okay, the ciliated cells move the mucus. The mucus, being sufficiently sticky, traps particles, invaders. The cilia move it, basically all moving toward the oral opening, whether down or up or forward, and we expel it or swallow it or do whatever we're going to do. We get rid of it, one way, shape, or form. So all of that type of stuff. You go into the physiology, the mucus is very interesting. It's got a proteinaceous part, which is more thick, the watery part, which we call serous. There's a lot of defensive particles. You probably did you do your immune unit yet with lysozyme and defenses? That's all here, and that's it. And so there's a lot of blood supply. That's why if you get a bloody nose, it bleeds kind of a lot, comparatively speaking. A lot, very, very sensitive. So you not only does it generate sneezing, but I mean, if you strike it or you bump it, it hurts quite a bit, almost disproportionately so. The conchae, you probably learned about a bit in anatomy. In the bone portion, they're really about surface area. And that's all you have to say about them. Not a whole lot. Okay, sinuses are here, what they do, the 4 bones. There's one back here in the temporal bone called the mastoid area. That's another resonating chamber. It's more about hearing than it is about respiratory than anything else. And so you can see it here. The little openings are like little cul-de-sacs into those sinuses. It's good news and bad news, because while they help resonate and lighten, the trouble is infections get in there. For those in micro, I don't know if you're going to do the unit depending on who's doing the micro. For those that have me, we do a whole unit on respiratory diseases. People in other classes could come and listen or get the recording sent to them if they asked. Not that it would be anybody in the room. I only give Riley a hard time 1 day a week. 1 day. It's very upsetting. And and because it's an opening, anytime you have an opening exposed to the outside, you did the lymphatic unit. You have a lot of lymphatic tissue that's exposed. They're like little sentinels. They're sort of watching. Okay, they're sentries, if you will, looking for potential invaders. So they're constantly sampling the environment that are there. And inflammations, rhinitis, typically what you get with a cold, sinusitis. If you get to it in micro, they're typically caused by the same subset of viruses and bacteria pretty consistently. A shared system between digestive and respiratory is the pharynx. The pharynx is like, think of a funnel, and anteriorly it's somewhat open, would be the best way to describe it. Wider at the top, more narrow at the bottom. It's a muscular tube that participates in both respiration and digestive. 3 regions, depending on what structure they're behind. Behind the nose, there's the nasopharynx. That's where the eustachian tube enters, or exits, depending on your perspective. the oral behind your mouth, the laryngopharynx behind your larynx. Okay, there are the three areas. That's kind of the area for the eustachian or pharyngeo-auditory or tympanic tube that's there. Why is that important? We'll get to it in a second. Hey, let me keep going with this laryngopharynx, posterior to the epiglottis, and we'll get to that. These areas, because food is passing, have slightly different epithelium. You're going to have stratified squamous because they're more protective, non-keratinizing, more frictional component in and around that area because food is passing that way too. So there's a certain amount of abrasion. That's why you see layered epithelium. And so here, all the stuff that's there, different tonsils. The pharyngeal tonsils are known as adenoids. Common procedure that was done for forever, tonsils and adenoids. In my day and age, if a kid had 2 ear infections, their tonsils went out. Mine were just like that, 1956. I know. Long time ago. The galaxy far, far away. All that type of stuff. Okay, which brings us to the rest of it. They kind of skipped the ear thing, but I'll remind you, because I probably mentioned it before, that too is one of the anatomical bases of disease. There are 2 of these in this unit. The tympanic tube or eustachian tube is oriented in babies horizontally. So when a baby sleeps on its back like that, drainage from like a nose infection, viral or bacterial, go right back to their ears and it'll clog. By somewhere between age 2 and 4, that tube, as the baby grows, becomes pointed more downward. And then we see that ending, more or less. Okay, so usually sometime 2, 4, 5 years old, kids don't have nearly as many ear infections. It's anatomical in nature. That's there. As a kid, I missed a third of kindergarten with ear infections, and then subsequently had my tonsils out. And in today's world, that probably wouldn't have happened. I've been like my daughter getting a couple of sets of tubes in her ear. She still doesn't listen to me. So she's 37. She doesn't have to listen to me. Remind me next time I have another good picture of her that I can put in public without having to risk being banned. So here we have, now we get to this area in the lower. They started with the larynx, trachea, bronchi, and lungs. The respiratory zone where gas is exchanged way down as we start to get into the alveolar area. The point of transition, everyone, are respiratory bronchioles. A respiratory bronchiole does not have any cartilage because cartilage, whole reason for being in the respiratory system is patency. Patency means holding it open. Whether they're rings, whether they're C-shaped, whether they're plates, what they're doing is because there's a rigid substance in there, if the muscles go into spasm, it doesn't close the opening. A respiratory bronchiole no longer has cartilage, disappeared. It's made out of lining tissue and some muscle tissue. And what you can see in a respiratory bronchiole opening up are openings to alveoli or alveoli themselves. Up until that point, the last structure that has cartilage in it is called a terminal bronchiole. It may only have an isolated fragment or plate, but it's enough to hold that a little more opening, and you don't have openings directly into alveoli. So the conducting zone is everything from your nose down to the terminal bronchioles. Its purpose is to move air in and out. Most of that is accomplished by pressure changes. Okay, it's not active in the sense. Inhaling and exhaling certainly assists it. Okay, but a lot of it has to do with a pressure gradient that is there between atmospheric pressure and internal pressure. And it's enhanced when we expand our chest cavity and our lung. The whole, if you did the physiology or you're going to do it, the whole idea, whole thing relates to chemistry basically. Ideal gas. Is that ringing a bell for anybody? No? Ideal basketball PV equals pressure and volume of concentration. That's proportional. So if the pressure lowers, volume increases. If I increase my chest volume, it lowers the pressure. It's lower than more than atmospheric pressure air is coming in. When I exhale and reduce the volume, the pressure increases, pushes the air out. The air out. Yeah. And all those wonderful laws, you have to do all those laws, Charles laws, whatever. That, do you remember that from lecture? No, you didn't do that? What? You didn't get to that. You're really out of sequence. It's been an adventure. So, I'm very sad. I won't get to have the entry level students I was telling Hannah about it earlier. Next year, everything's changing. We have less students and more teachers, so I'm going to have to do more labs. So when they come and ask me, who should I take for micro? I'm not going to be there. That's what you recommend me. I know. Sorry. Life is full of little surprises. So, all right, 3 more years, they won't have me to kick around. Bound and determined to make it till I'm 75. Right? So, conducting does all that good stuff. The larynx, I don't care, that's 3rd and 6th vertebrae. Patent airway because it's surrounded by cartilage, voice production. I don't do the voice thing. I'm just not good at it. Right? Somebody wants me. Oh, okay. My stepson. Sorry. I'll respond to him later. So here we have. There are 9 cartilages. Only have to know 3 of them. You've seen them somewhere. There's a model that I got up and was looking for before. I have no idea. A lot of times they disappear around here. Probably on a table someplace. But I mean, irons. I'm very disappointed. I'll find it. Heaven forbid. All right, here we go. So the 3 cartilages are the epiglottis. Remember, the pharynx is a shared tube. And so it's got an elastic cartilage so that when you swallow, it covers the trachea, because when the pharynx divides, it divides into the esophagus and the trachea. When you swallow, that flaps down and covers the trachea. So, like your mom said, don't talk when you eat. Because my mom said that. Okay? So you're not someone's going to have to go over and Heimlich maneuver you because you did something silly. All right? That's the epiglottis, the only elastic cartilage. Everything else is hyaline. The thyroid cartilage, as they describe it, much larger anteriorly than posteriorly. It's like a shield, open book. The spine of the book, which starts to grow as we reach puberty, more so in men than in women, is what we call an Adam's apple. The ring-shaped cartilage below it, which is larger posteriorly than anteriorly, is the cricoid cartilage. I don't really care about these paired retinoid, cuneiform, and cornicular cartilages. Okay, this is during swallowing, covered in taste buds. You can see it here. Here you have the Adam's apple, the hyoid. So you can actually palpate these. I'm not very good with that. The hyoid is that one bone, and you can see it on most of these. It's really more appropriate to talk about muscles. I mean, it's not even on here, like over here. It's the only bone that doesn't articulate. It would feel it doesn't go like right? But they tell you in kindergarten. I used to get the rubber Lewis doesn't play well with others. Now I'm wondering what I really do like that. But it's only got muscle attachment, so it's really just like a fulcrum or an anchor for a variety of muscles. that you can actually feel. It's important forensically because a lot of times we'll show someone's been strangled. You'll see fractured hyoid bones that are there. So you can palpate that, but you can easily palpate this here. You can feel it. So you can feel certainly the Adam's apple and the area around the car. And it's really an important landmark. And it's like down here with that notch. I mean, if you have to trach somebody, it's right in there because you're midline and you avoid great vessels and things like that. It's something in an emergency situation. So it depends on what you do with your lives. So here's what it looks like. We have a model that's not bad. You have the hyoid up here. This is the top of the epiglottis that'll flap down here, wide anteriorly, the thyroid cartilage, because the thyroid's here and the thyroid's here. Adam's apple is the prominent centrally. There's a ligament, obviously. The cricoid cartilage below it, more narrow anteriorly, wider posteriorly. And then you have vocal cords and folds, which I don't do. And the opening between them is the glottis. I never really learned a lot about the mechanics of speaking and things like that. So that's why I don't bother to tell you about it. Okay. Again, stratified squamous on the upper portion, still somewhat protective. Then once you get below the vocal cords, now it's all pseudostratified ciliated columnar. That's a dissected piece. This is the side view. You can see a little bit better. Anterior, the thyroid cartilage. I'll find the model, I'm sure. Posteriorly, the cricoid cartilage. You can see wider in the back. And then to start, as you immediately get below it, now you get the tracheal rings that are there. And that's what the glottis looks like. That's useful if any of you would want to go into anesthesia, be like a CRNA. It's a wonderful field. This is the view that you see when you're introducing a laryngoscope, and through the laryngoscope is where you would do an endotracheal tube. And the big problem is if you don't go through here, you end up going by mistake into the esophagus. You're not helping anybody breathe. That's why the tube placement is so important. I have never done it, so I can't comment on it. So even when we're a resident or a student, or even if I was a surgeon, that was the job of the anesthesia people. The anesthetist or the CRNA did all that stuff. And don't do the voice. Valsalving is we do it when we strain to go to the bathroom, where we're lifting something, stabilizing the trunk, all that type of stuff. That's what that is. And we sort of vary that when we do the Heimlich. It's not really valsalving, it's just introducing a sharp pressure under the diaphragm to try to force something else. And you may or may not have to do that. You can even do it to yourself. Okay? In laryngitis, swelling, vocal, etc. To the trachea we go. So what's interesting with the trachea is it extends from the larynx into that mediastinal area. So now we're on the process we're still in the neck, but we're going into the chest cavity. And it terminates by bifurcating, forking into the two main bronchi. You can use the term main or primary. What's unique about that are the rings. It's only about 4 inches long. As you can see, the diameter is about 3/4 of an inch. It is a very flexible structure. With regard to the soft tissue as such, between that, the connective tissue. So if we get one of those things out, let's say next week, detect it or demonstrate it, you see it's fairly flexible. Because there's a lot of give. That's why you can, in surgery, if we're doing neck surgery, like on the vertebrae and cervical area, you go anterior because you can retract that out of the way and stabilize. These are go in the back, there's so much muscle. So if the rings are C-shaped like this, open posteriorly, there's a muscle called the trachealis. It has a certain amount of give because as food passes, it has to have a certain amount of expanse on nature to it. And every so often we bite something that's a little too big. Pizza in there. I always cut pizza into 8 pieces because I can't eat 6. The other way around. Right? Love that. Pizza sounds like dinner tonight, I'm thinking. So cilia is pseudostratified, submucosa, mostly connective tissue, flexible. Okay, some seromucous glands, 16 to 20 of those C-shaped ones. Adventitia is the connective tissue on the outside that's by definition not moist. It's dry. Even though it moves, it's not sliding over other structures. That's when we get to something called serosa, which we'll see in the digestive area. Trachealis muscle posteriorly plays a role in expelling, and what's unique is the bottom cartilage. It's triangular, flat on top, sort of angled at the bottom, and the openings at the bottom. Here you go. Find someplace quiet and do this.
Thank you.
Not in here. I'll meet you over. Do you know where the atrium is over by the science offices?
I believe so.
Go there. I'll meet you there. You're just right on.
Okay.
Goodbye. Who is this? So it's very interesting. It's a very sensitive area when little particles, that really what triggers coughing. It's really important. You will see it. So this is the typical way the cartilage look. The middle layer, I mean, you have the lining. The middle layer is basically cartilage, and outside, I mean, there's a tiny amount. The submucosa is more cartilage and maybe a little glandular structure. And then outside, you have the adventitia. Here's the trachealis. Here's the esophagus. We'll get to the layers of that in 2 weeks. As you look here, you can see it now. This is what's pseudostratified ciliated columnar. It looks like it's multiple levels, but all of those cells go down to the base. They don't all necessarily go to the top. It's a sort of unique structure. There's the cartilage, there's the adventitia. That's healthy cilia, what they look like. If I have seen the ones with people who are chronic, mine would have looked like 15 years ago. You would be scared. Okay, all this bad stuff about smoking that's there. Okay, and the remarkable thing, within a matter of weeks, they grow back. So I will tell you what I told my other class today on the very same topic, and it's very sobering. If you know someone, and there aren't as many smokers as there used to be, but if you know someone who maybe has less than what's called, we judge smoking in terms of what we call pack years. So when you're interviewing a patient, how many cigarettes do you smoke a day? Oh, I have about half a pack. That's a pack. It's like drinkers. They're always undervalued. How long have you been doing it? Oh, 5 years. That's 10. So if they do it, it's a pack a day for 10 years. That's 10 pack years in the parlance. Once you get to about 20, the damage is done. Those cilia will regenerate. You'll breathe better. You'll speak better. You'll get less colds. I'm talking about me. Your risk of cancer will not diminish. If they find a, quote, spot in my lung, which thankfully they have not, the odds are 85% that it would be cancerous. Period. End of sentence. My mom was in the same boat. My mom smoked 3 packs a day for 30 years. Everybody did back at her age. My mom was born in 1918. Okay. She's quit reluctantly in 1967. I know. She and I like smoking. We're terrible. It's awful. So these are life-threatening. Here's the Heimlich, etc. So what happens when it begins to split? Once you get to that end part of the trachea, the carina, it splits and it forms the remaining structures of the conducting zone leading to the respiratory zone. They're called primary or main bronchi. This is another significant anatomical basis of disease. I'll reiterate this in micro. On the right, it kind of goes straight down. On the left, it makes a left turn. It's going over the heart. One's vertical, one's more horizontal. Most pneumonia are right side. It's gravity. It's easy to go down the right. It's hard to get to the left. If you have a lot of particles or a lot of bacteria or a lot of viral particles, then you can get something called double pneumonia. Normally, the pneumonia is one-sided. Double implies that it's both sided. So each one enters the lung. The area of the lung on either side where the pulmonary vessels enter, the arteries, the veins exit, a variety of other structures enter, and in particular where the bronchi enter are called the hilum. Your kidney's got one, your liver has a similar area. We'll get to all of those down the road. So once they enter, they break apart. There's like 23 orders of breaking apart. In other words, getting smaller and smaller, but many more of them. So the right is wider, shorter, and vertical. Each one enters the lung. Each main gives rise to secondary bronchi. 3 on the right, 2 on the left. The left is technically a little smaller because the heart is it has altered it just by it forming around or the heart pressing upon it. And so there are 3 lobes on the right, superior, middle, and inferior, but superior and inferior on the left. They give rise, in the old days we used to call them lobular bronchi. Now we call them segments. There's roughly 10 on each side, maybe 9 or 10 depending on the author on the left, 10 certainly on the right. And then they begin to divide. When they get to the point where you can't see them with the naked eye, they make the transition into what are called bronchioles. Just like an arteriole, that diminutive suffix typically implies you can't see them. Okay, they're interesting because they're so narrow and the cartilage has given away to more smooth muscle. When they spasm, air can't get through. That, and if you know somebody, when you see them having an asthmatic attack, it's bronchiolar, not bronchi spasming, because there's not enough muscle there to close them up. Bronchioles, just like arterioles, you have enough muscle that it can squeeze it. That's where in the blood supply where we govern blood pressure. Okay, in respiratory, that's the critical zone. When someone has bronchiolar spasm from asthma or anaphylactic shock, you can't do a tracheotomy. That's just going to open the opening. Tracheotomies are when there's problems around the larynx. It's not going to do anything on the inside. That's where the EpiPen comes in, or other methods that are there. And everybody probably knows somebody who has an EpiPen that they have to carry along with them, whether it's bee stings or nut allergies or things like that. So the terminal bronchioles are smaller still, less than 0.5 millimeter. You really can't see them. And so this is kind of what it looks like. There's the carina. You can see the openings. This one on the right goes pretty much directly down. Here's the heart indentation. So you have 1 secondary bronchus, 2 secondary bronchi, and the 3rd secondary bronchi that are there. And then all of these are segmental, superior, middle, and inferior. Superior and inferior. You just have 2 here. 1 going down to the inferior and 1 going up of the secondary bronchi. So what happens as it makes the transition, they start as bronchi, as rings of cartilage with just a little bit of connective tissue. They eventually transition to plates with more elastic fibers, and the pseudostratified, as it gets closer and closer to the alveoli where the exchange, they give rise to cuboidal cells. Okay, cilia and goblet are much less apparent. The smooth muscle increases. That's what I was telling you about. So that's where the resistance is to air passageway. And we have the remarkable capability when an area is clogged or damaged because you had pneumonia in the past or a lung infection or irritation in the past. Interestingly, air will go to the areas where it's best utilized. It's remarkable, and that's what I mean. That's sort of that two-edged sword kind of a thing. So where do we make the transition from conducting to exchange? At the respiratory zone or the respiratory or exchange zone, respiratory bronchioles, and how you see them, you begin to see alveoli, these clusters of cells that you're in micro that kind of look like you're looking at staph under the microscope, grape-like clusters of cells. So as you can see, the alveoli, 300 million, make up most of the lung volume. That's where the exchange. So it's a really good illustration. Here's a bronchial, terminal bronchial. When it divides and we start to see the alveoli, and you can see the little dividers there are a lot of elastic fibers. They expand and contract. That's the beauty about lungs. And what they make when you reach about 26 weeks of gestation, something called surfactant. Surfactant is made by a cell we're going to see shortly called type 2 cell. It's a wetting agent, moist, so that when you inhale and exhale, they expand and contract. But when they contract, they don't adhere to one another. That's what surfactant does. That's for years until we made that material. When the baby was born, 26 weeks converted prematurely. Now, 4.5 weeks, babies can survive. And I have a lot of students that graduate here on neonatal things like that. One's not, I still to some extent keep in contact. That steps are fine. We just texted one of the two of the girls he graduated with. I still, every so often see them. So the elastic fibers are significant too. And those are the kinds of things that are damaged by environmental factors, by smoking, by lifestyles that are if I only knew. This is what it's kind of like. You took a piece of lung and you sliced it the long way, put stain on it, put it on a piece of paper. That's how you look at it. So this is where the air is that you're inhaling and exhaling. All of this, all that little fine line stuff, those are cells that allow the exchange. When it's thicker and denser, they're blood vessels, or those are bronchioles. And now we're into the alveoli. The more of this you have, the easier it is to breathe. When people have emphysema or lung damage, what happens is these areas get wider. The air, there's less surface area for exchange. There's more air that's stuck in the lung that with no place to go, and it gets stuck in there. It gets trapped. What is the word for trapped air? Emphysema. Emphysema isn't confined to the lung. Emphysema is trapped air. In micro, if you cover something called a flesh-eating disease, okay, you're going to learn that that is identified radiographically with an X-ray with what's called subcutaneous emphysema. Gas gangrene is the same thing, trapped air. In this case, it's when we use the term emphysema, the assumption is unless otherwise stated. So that's what it looks like. So when you see somebody with a damaged lung, you see thickened areas, you see irregularities, you see fibrosis, darker, thicker staining, and big, wider gaps that are there. So the beautiful thing about this barrier is you have a simple squamous cell on the alveolar side, a simple squamous cell on the capillary side, and in between it, basement membrane. So they share a basement membrane, and all it is cell membrane on either side. So it makes it very easy for oxygen and carbon dioxide to go across. There's nothing in between. So it's perfectly constructed for simple diffusion. Simple diffusion doesn't preclude multiple substances going in opposite directions. So oxygen can go in and carbon dioxide can go out. Dare I say, in with the good air and out with the bad. Shut up. They know you've already said that 6 times. Those cells of squamous epithelium are called type 1. Type 2 are cuboidal. They manufacture the surfactant. Other things, elastic fibers, and you're going to see subsequently everywhere there's a bronchi, there's a bronchiole, there's a terminal bronchiole, there's a respiratory bronchiole, or there's a cluster of alveoli, there is a blood vessel. It has a capillary, or it has an artery and a vein surrounding it. So they're extraordinarily well vascularized. Good news and bad news. When there's an infection in the lung, or cancer in the lung, and the lung breaks down, it easily gets into the bloodstream and spreads. We call metastasize. In tuberculosis, if it breaks through, the tuberculosis can spread all over the body. That's the bad news. Whenever you have a lot of circulation, that's a passageway for disease to spread or a cancer to spread. The pores equalize air pressure. Alternative routes, good design. We have tons of these. They're called macrophages. They're supposed to be there. The interior of your lung, by definition, is supposed to be sterile. Nowadays, we know that there are some resident bacteria that are more helpers than anything else. But basically, we get rid of millions of these every hour that we swallow or expel one way or another. Okay, so we're constantly making them. The bad news about that is these kinds of macrophages and other white blood cells are where some of the worst cancers come from. Okay? Something called small cell or oat cell carcinomas. That is not a diagnosis you want to have. It's a very, very poor prognosis. That's the illustration. So around, whether it's an arterial, a bronchial, this would be a venial, this would be an arterial, or the other way around because it's pulmonary. Around the alveoli, you have this bed of capillaries. It's constant exchange. That's what it looks like from a casting, scanning electron micrograph. Here we're looking inside. That's where you get the puzzle ball analogy. You have the nucleus, you have the squamous cell, you have macrophages, you have the type 2 cells, you have blood vessels that are part of the capillary bed. They're all there. I love that. So we're almost done, thank goodness, for today. The side of vascular and bronchial, the root of the lung, is really where, in the root, that's the entry and exit points. The costal surface means against the ribs, anterior, sideways, posterior, the apex under your clavicle, okay, the base on top of your diaphragm. The hilum is that entry and exit point for everything. There are, again, the notch on the left. You can just detect the lobes based on these, I would call them somewhat subtle fissures, or not important to us, okay? Not really important to us whatsoever. So you can see it here. The beauty of this is you have lining on the lung itself. And you remember, this is the first lecture of AP1 that I do, and most people do. You have the pleura is that fine layer of lining that's moist. You have one on the lung called visceral pleura, and you have one on the wall of the chest cavity called parietal pleura. There's a tiny bit of moisture in there that's fluid because these structures move against one another. The great thing about that, when you expand your chest, what helps to expand the lung on top of the pressure change is it pulls the lung open, is you have fluid, you have surface tension of the two fluids. So some of the lung indirectly is pulled open by when you expand your chest because your diaphragm is flattening and your muscles are contracting that allow that to happen. That's just a side view into the hilar area. And the beauty of these chambers is they're separate. These one can function even if the other one is damaged. It's all about pressure. So when you hear about someone having a collapsed lung, it's because something has violated this space and it has allowed the external pressure to come in. Maybe it's violated the pleura. Maybe it's a fractured rib. And what happens is a lung collapses. It's got a fancy name called atelectasis. And what you have to do, one lung can hold you for a while, but if you don't reinflate that lung, it begins to adhere to itself so securely, it makes reinflation very difficult. And so we would see this all the time with motor vehicle accidents. Before, in the age before, airbags were around. They'd hit the steering wheel, they couldn't breathe, we'd bring them in the emergency room, and residents forever were excited about being able to pass something called a chest tube. So you put that in, basically cutting a hole, sucking out the air to reinflate the lung, and then eventually advancing it and removing it, pulling it out, and once the lung started to heal. So the segments themselves, 10 on the right, depending on the author, 8, 9, 10 on the left. Dividers called septa. They all have their own little. Nowadays, you don't see it as much, but in the old days, they'd have to remove the entire lung if it was damaged or diseased or cancerous. Now they can address it just segmentally because their surgical techniques have improved. The lobules are now the smallest divisions. They used to be the segments. And the lungs are mostly composed of those alveoli. And the rest is some elastic connective tissue. They're squeezy and spongy. Okay. So it's interesting how you can remove them, and you'll see it. I should get one of those out when we meet next time. That's the casting of it. You can see I beg your pardon, all the order. I mean, it really gets small in a big hurry. And the rest is circulatory we're not doing. Uh, they don't derive nourishment from the pulmonary vessels. They're called bronchial vessels. They enter at the hilum, coming from the aorta. They're part of the systemic circulation. And there's the pleura, parietal, and visceral fluid. Pleurisy is inflammation. It feels like a sharp pain when you breathe along here, called a friction rub. There's certain sounds that you'll learn about in the clinical nursing. Many of you will be able to discern that. Again, I don't have the ear for it, that are there, and fluid can accumulate from a variety of reasons that are there. We're done. Aren't you happy? Next time, we're going to look at a lung. We're going to I'm going to insist on a couple of volunteers to try to breathe. So we'll see how lungy you are, and we'll go from there. All right, everybody. Thank you very much. Nice talking to you.